cardiovascular assessment. First, perform hand hygiene, introduce yourself to the patient, confirm the patient's identity, begin to explain the procedure, and ask any questions related to health history that you need to ask. So, have you had any history of heart disease or hypertension?
No.
You or your family?
No.
Do you ever experience any kind of chest pain?
No.
Good. So then we'll first start off with inspecting for jugular vein distension. So we're going to look at the patient's neck, and could I just have you turn your head to the left? And I'm just looking at the jugular vein. You shouldn't be able to see any kind of protruding vein that could indicate distension, which could be caused by fluid volume overload or congestive heart failure. And I'm not seeing anything. It is flat, which is normal. And then while I'm here, I could assess the carotid pulses. Then I'll go ahead and palpate the carotid arteries. So I'll start with this one. And I want to be sure to only do one at a time and to not palpate the carotid sinus too much. So I'll do it right about in the middle of the neck. I'm just going to palpate that. Feeling for any kind of thrill or vibration, which I don't feel. Feeling a regular rhythm. You can turn your head this way. And do the other side as well. And they both have an amplitude of about a +2, which is normal. Pulses are graded between 0 and 4, with 2 being normal, 1 being weak and thready, and 4 being a bounding pulse. And so hers felt normal. They were symmetrical on both sides, and I didn't feel any kind of thrill or pulse or vibration. And then I'm going to listen to the carotid arteries for bruits, which is a kind of swooshing sound that indicates turbulent blood flow caused by some kind of obstruction, possibly a blood clot or arthrosclerotic narrowing of the artery could also cause turbulent blood flow. So I'm just going to listen to each one of those with the bell of my stethoscope. Could I have you turn your head to the left again? So now I'm auscultating the carotid artery. And could I have you take a breath in and out, and then just hold it after you breathe out? So I'm hearing the pulsation, but I'm not hearing any kind of turbulent noise. And I'm going to have you do the same thing. If you could just look this way, and then breathe in and out, and then hold that. And I can hear the pulsation, but no bruit is present there either, so that's good. Next, we can move on to the cardiovascular, and we'll start off by just inspecting the anterior chest, inspecting the precordium, the chest area over the heart, and I'm looking for symmetry of the chest, any kind of scarring. I'm looking for lifts or heaves, which would be a visible moving up of the chest caused by possibly an increased workload of the heart. And I look at those at the 5 landmark locations of the precordium. And then I'm also going to palpate those here in a second. And I don't see any visible heaves, so we'll go ahead and palpate. And I'm going to palpate each of the 5 points, and I'm feeling for thrills or those vibration type feelings that in this area will also most likely coincide with some kind of murmur that will be audible with the stethoscope. So I'm going to start off, and I'm just going to Find the 5 landmark locations, the first one being the aortic area at the second intercostal space on the right sternal border. And I don't feel any kind of thrill or palpation there. The second intercostal space on the left sternal border is the pulmonic area. The third intercostal space on the left sternal border is Erb's point. And the fourth intercostal space on the left sternal border is the tricuspid area. And then the fifth intercostal space at the mid-clavicular line is the mitral, and is also the apical point, the point of maximum impulse. And here I can feel some pulsation, which is normal. And you may also be able to visibly see some pulsation there, which is normal, but it shouldn't be too pronounced. So I didn't feel any thrills there while I was palpating. And so then I can move on to auscultation. And I'm going to be listening at each of the 5 points, and I'm going to be listening for the regular heart sounds, S1 and S2, which are the lub and the dub. S1 being the closure of the atrioventricular valves, S2 being the closure of the semilunar valves. I'll also be listening for extra heart sounds, S3 and S4. S3 occurring right after S2, and it can sometimes sound like a gallop. S4 occurring at the end of diastole, right before S1, and that can have a thud-like quality. It'll be right before the S1 and the S2. I'll also be listening for murmurs, so any kind of, could be like a swishing sound, or it has a variety of different sounds. Some kind of abnormal heart sound that could be caused by turbulent blood flow or some other pathology. And those could occur at any point in the cardiac cycle. So I'm going to auscultate using the diaphragm of my stethoscope. First at the aortic area. Then at the pulmonic. Then I'll listen at Erb's point. The tricuspid area. And the mitral area. Good. And I'm hearing those S1 and the S2, the lub and the dub, and I'm not hearing any extra sounds. I'm also going to auscultate with the bell for lower pitch sounds at each of those 5 points. The aortic. The pulmonic. Erb's point. The tricuspid. And the mitral. I'm also going to have you roll to your left side a little bit, just like that. And I'm going to listen to the apical pulse there. Sometimes murmurs at the mitral valve can be better heard when the patient is laying on their left side. And then I'm going to have you sit up a little bit. And I'm going to listen to the aortic and the pulmonic areas, murmurs in those those areas can be better heard sometimes when the patient is sitting upright, slightly forward. And I'm going to use the diaphragm of the stethoscope here. The aortic area. And the pulmonic. Good, you can lay back down. And I didn't hear any abnormal heart sounds, no murmurs, no S3 or S4. It was all the normal lub-dub. Another thing that you might hear is a S2 split, which can be normal, which is caused when the patient, upon inspiration, the pulmonic valve is slightly delayed in its closing compared to the aortic valve. But I did not hear that in this case. I'm going to go ahead and I'm going to auscultate the apical pulse for 60 seconds and take that pulse rate, and then I'll compare that with the radial pulse rate to see if there's any kind of pulse deficit. So I'm going to use the diaphragm of the stethoscope again and just get the apical pulse rate. The apical pulse rate was 60, which is normal. Anything between 60 and 100 for your average person. Sometimes athletes, resting heart rate can be a little bit lower, between 40 and 60. So 60 is a good pulse rate. I'm just going to go ahead and take your radial pulse also, and we'll compare those. And that was 60 as well. So there's no pulse deficit, which is good. And a resting heart rate of 60 is very good. All right, next I'm going to assess the peripheral vascular system. And I'm going to go ahead and identify the peripheral pulses and assess them for the rhythm, whether it's regular or irregular. Assess the amplitude from 0 to 4, and assess the symmetry from side to side. So I'll start with the radial, which I just did. And that's about a +2, which is normal. And I'll do this radial as well. Good, and that feels like a +2. And a regular rhythm, and those feel symmetrical. Next I'll take the brachial. It's also about a +2, regular rhythm. Do this side. +2. Rhythm feels regular. Those are symmetrical as well. Next, I'll feel for the femoral pulse. We've got a +2 regular rhythm. +2. Rhythm is regular. Those are symmetrical. Next, I'll do the popliteal pulses. Just have you flex your knee a little bit. That feels like about a +1, maybe +2. Sometimes the popliteal is a little bit harder to feel, so it could just be for that reason. And that's about a 1 or a 2 as well. And it feels regular, so those are symmetrical. Next will be the posterior tibial. And that feels like a +2 regular rhythm. And that's a +2 regular as well. You mind if I remove your socks?
Sure. Both of them?
Yeah. That'll be the last of the pulses, and it's the dorsalis pedis. And that is a +2 regular rhythm. And that's a +2. And the rhythm is also regular. So those are all of her peripheral pulses were symmetrical, mostly at a +2 with a regular rhythm. If a pulse is irregular and you're taking the pulse rate, you then have to listen for a full minute to do so. The last thing I'll do is an Allen's test. So what I'm going to have you do is put your hand out like this and then make a fist, and I'm going to occlude both of your arteries, your radial and your ulnar arteries, and then I'll have you open and I'll release one, and we're going to see your palm will be white, and then it will redden up as the blood flow returns, and we'll see how long it takes for the blood flow to return. So you could just go ahead and make a fist and open. So we'll open up the radial, and it took about 3 seconds for the blood flow to return, which between 3 and 5 is normal. So if you do it again, make a fist. Include both sides. Open up. And we'll let the ulnar go. And that was about 3 seconds as well. Next we'll do the other one. Go ahead and remove your watch. Thank you. Go over. Fist. Open. Your radial. And that was about 4 seconds, which is normal. Go ahead and let go. And then the ulnar. That was about 4 seconds also. So those are both normal findings. So all of our findings were normal. I've tried to have the patient in a 30 to 45 degree angle as best best we could without having an actual examination table. And that should conclude our assessment.